So we start the session and I invite Dr. Ashok Sharma, the first speaker for his talk.
Respected member on the dais and friends, I would speak on deep anterior lamellar keratoplasty long-term results. Authors have no financial interest. Corneal perforations need urgent management. Corneal perforations less than 3 millimeters are managed with sinoacular tissue adhesive. More than 3 millimeter perforations require tissue scaffold to apply sinoacular tissue adhesive. Two scaffolds have been used, scleral patch or Tenen patch. More than 3 millimeter perforations are mostly treated with therapeutic penetrating keratoplasty. Therapeutic DALK has advantage over penetrating keratoplasty, but there are not many studies on this area. This is a retrospective interventional case series. IRB approval and study has been done retrospectively. Comprehensive ophthalmic examination, microbiological workup and autoimmune disease workup was done. These are the consecutive patients of and comprised of 41 patients. Only patients who had to be converted to PKP intraoperatively, they were excluded. There were three surgical techniques which were used. Ab externo manual dissection, layer by layer, was used for most of the corneal perforations. Combined ab externo and ab interno dissection, as shown in this diagram, was in this figure was done. Partial trephination, and after partial trephination, the superficial corneal stroma was removed. On desmatoceles or impending corneal perforations, the deeper Descemet's membrane and deeper stroma was separated using a blunt-tipped spatula. Bearing of the Descemet's membrane was done, and then dark patch donor graft was applied. In some of the patients where we had cricentric Murren's ulceration with perforation, we used no dissection of the host tissue, but customized lenticular preparation was done using two turfines. Making it a geometrical shape, the tissue was required. We had almost 88% success in achieving in eliminating the disease. And these are some of the cases. Murren's ulcer patient with perforation, he came in COVID-19 era, and he was done DALK. And he had good visual acuity 6.9. Neurotrophic corneal ulcer, then post-bacterial corneal perforation, all treated with DALK patches. Now this is one patient who had severe dry eye along with impending perforation. Once he was treated for dry eye, he developed impending corneal perforation. We had choice of tissue adhesive plus DALK, but due to COVID-19, we went for DALK so that no more visits were required. Having good visual acuity, so he was ambulatory. Another patient who had herpes simplex keratitis and was operated with DALK. Some of these patients who were treated for post-fungal corneal perforations, they had recurrences. And same was true for herpes. Secondary glaucoma, cataract and retinal detachment were some of the other complications. I would like to say that minimal invasive DALK is minimal invasive and faster healing, spares the angle, and there is a lower incidence of glaucoma. Combined ab externo and ab interno technique in addition to tectonic provides good visual outcome in some of the cases. Customized donor lenticule preparation with two turfines is easier than manual technique because it is very difficult to cut the full thickness donor cornea to the desired shape. Another advantage is that the glycerine preserved donor tissue can be utilized. Therapeutic DALK can be useful during pandemic conditions like COVID-19. I would like to conclude by saying that therapeutic DALK is a safe alternative to PKP in selected cases. In addition to tectonic support, elimination of the disease may improve the visual acuity. And therapeutic DALK, if we have to perform, we should be cautious in selecting cases of fungal and herpes simplex keratitis as there is high risk of recurrence following therapeutic DALK. Thank you very much for patient hearing.
Excellent presentation, sir. Ma'am, please.
Please go ahead. I just wanted to know that this was only for peripheral ulcers or this is for the central perforations also?
I have done for central perforation also and peripheral perforation.
So how do you get the endothelium in that area, in that perforation area? Because if you said that the perforation is larger than 3 millimeter, and then that area will remain devoid of perforation.
Yes, madam. Then the trephination, partial trephination will be done.
And the endothelial part, how the endothelium is arrived at that place?
How the
Because
endothelium?
unless endothelium will not grow and cover that area, so that area will remain without endothelium.
No, madam. What has happened is that
Was
if the perforation is small, and if we apply a lamellar patch over it, then the endothelial cells, they enlarge and they cross over the host gum junction and they cover that area. I have published one case report in which there was a peripheral corneal perforation, full thickness, and we did glycerin preserved graft, which was stored for more than 2 months in the glycerin.
It's good
and
for peripheral
that
perforation.
and
That's
that
what I
patch
was
also,
asking
and
you.
that patch also cleared. So endothelium slides over and clears.
Good, thank you.
Would you, in case of fungal, like you said, it is used in selective cases, right? So would you recommend doing this in fungal corneal ulcer with perforation?
No.
Because you have included some cases. So,
No.
So suppose if you see today one case with perforation and fungal corneal ulcer, proven fungal maybe, and what would be your first procedure of choice in such cases?
Well, you see, if
Because I think we have to be very cautious in recommending such procedures in fungal ulcers at least.
that's what you see, even for like non-dissolving fungal keratitis, with all the antifungals, the deep anterior lamellar keratoplasty has been tried. And in that case also there is a high risk of recurrences.
Yes. And
So we
recurrence
thought,
is again very difficult to
and
treat in that.
in these patients where the like already because we are treating with the fungus or bacterial ulcer, the collagenolysis occurs and then the perforation occurs.
Yeah.
So most of the time the infection is relatively under control, but still in fungal cases recurrences occurred. So that
this
is the
not
problem.
advisable in fungal.
I
as of
would
now.
not advise.
As of now.
I would advise
It just
penetrating.
retrospectively you have included because you have
My choice would be penetrating keratoplasty, therapeutic penetrating keratoplasty for fungal.
right. Thank you.
Thank you.
There are reports from Dr. Donald Tang also, like this from Singapore, that he has done some of these cases of complete perforation with DLK, but that was with peripheral perforations. So the visual acuity improves when the central cornea is clear. They are good reports.
No, she just mentioned that there are reports, previous reports, and mentioning the similar procedure. Yeah.
That's true.
So next we call upon the next paper, Novel Drug Repository Contact Lens Study Prolonging Antimicrobial Contact in Bacterial Keratitis, Dr. Lionel Raj.
Good afternoon, chairpersons, dear friends. I do not have any financial interest or relationships in the paper which relates to a drug repository contact lens in lengthening antibiotic corneal contact and hastening bacterial keratitis healing. Reports of a randomized control study. Up to 5% of all blindness are due to infections in the eyes, and in our region down south of India it's 11.3 per 10,000 population, so it's quite huge. So there is an unmet need and there is a strategy for novel therapies which has to come. And presently topical dosage forms are the treatment option in loading doses. However, precorneal factors and anatomical barriers, they negatively affect the bioavailability of drugs in the lesion. With this background, we propose to evaluate the efficacy of a novel therapeutic contact lens that increased overall contact time of corneal antimicrobial agent serving as a drug reservoir in subjects with BK. It's a randomized open label clinical trial. 40 eyes were randomized into group 1 and 2 in 1:1 ratio. Group 1 receiving only topical agents, whereas group 2 with the drug reservoir contact lens. 3 and 2 cases out of both the groups did not complete the study and were excluded from analysis. In both the groups, a standard dosing of moxifloxacin 0.5%, 2 hourly for the first 3 days and 4th hourly for the next 12 days were instituted. Followed up on 12 hours, days 1, 3, 5 and 14, and also a pain analog scale was followed. In addition, a drug availability study was also performed. So this is the proprietary design which has a dual base curve lens as to make a central reservoir and also fenestrations which enables capture of every time applied antimicrobial agents. The results. Corneal infiltration, the bacterial keratitis severity score was comparable between both the groups initially. However, the first 3 days, the effective healing was more in drug reservoir contact lens group. And the effective healing started after third day, that is on day 5 and day 14, till day 14 in the other group. That means hastening of healing happened with contact lens group. So this is a case of gram-positive ulcer, and this is by 12 hours, and by day 1 you can see more than 50% healing, and day 3 almost completely healed, measured by OCT also. Another case example wherein again by day 1 you can see a significant healing due to drug reservoir contact lenses. Pain was also comparable between either groups. However, pain reduction was very significantly better by 12 hours, 1 day and 3 days in the contact lens group. Similarly, a mean of 1.5 line improvement in vision was noticed by day 1, which improved by another line by day 3 in contact lens group. That means significant visual acuity gains were possible before day 3. The pain which I spoke, yes, the pain significantly reduced in the first 3 days in the contact lens group. And so did corneal haze and AC reactions. That all says that the first 3 days are crucial, and the first 3 days effective healing was better with the contact lens group. Ulcers which were more than 4 millimeter in size, the larger ulcers, the effective healing started in 1 to 3 days and resolved within 2 weeks. The drug retention studies, here we employed triamcinolone, which is used during surgeries, which doesn't stain lens but stains the vitreous, was used as a testing agent in our drug retention studies. And the drug availability in the precorneal space immediately peaked after application and stayed in the precorneal space till the period of 4 hours. That means the drug, antimicrobial drug, would remain in the precorneal space for 4 hours. So poor drug availability is a major concern. We aimed in retaining the drug in the precorneal space rather than a sustained drug release systems. And since all these parameters proved that before third day effective healing started, we recommend the treating physician, corneal physician, to use the lens for 3 days, and after 3 days they can continue or they can withdraw based on the clinical response. And further studies as well as extension studies are being done at our center, and also we are doing multicentric studies to gain more efficacy data. To conclude, drug repository contact lenses may be indicated for therapeutic use to promote effective healing and pain relief in bacterial keratitis. The concept of using novel drug repository contact lens over the lesion is effective in prolonging corneal antimicrobial availability, which can affect the overall outcomes in BK. And this can reduce the regimen of antibiotics, decrease the burden on the medical staff, it can improve patient tolerance, reduce drug toxicities, and may change the present practice pattern of loading dose concepts. Thank you for your listening.
About the contact lens, I mean, does it prevent you from evaluating the ulcer we do usually? I mean, the visibility and the scattering of light and, you know,
No.
other factors, the debris and which collects inside, because you are, once you put it, you are going to keep it for longer time, right?
Yeah, but during the study, that is what we recommend, at least for the first 3 days you do so. But during these studies, we remove the contact lens, we stain, we find out the lesion size also. And as you rightly said, we can have mucus strands,
Yeah.
especially on the fenestrations.
Yeah.
What we advocate is that you can wash with balanced salt solution. Or
So you have to
can
remove.
always remove, wash and reapply.
So patient has to come for those visits again and again.
We admitted because 12 hours, 1 day,
Okay.
this is a trial, randomized
This is a
trial.
trial.
So we can't have too much of, variants.
And were these bacterial culture proven
They
ulcers?
are,
And all were sensitive to moxifloxacin?
they are. I'll tell you how did we do, because the methodology, entire methodology we cannot squeeze.
I'm concerned all those ulcers were culture proven sensitive to
No,
moxifloxacin?
I'll tell you.
Yeah.
All the cases are proven BK by gram staining,
Okay.
and 80% were culture positive. So culture results,
But
we
not
will-
sensitivity was not done.
no, culture and antibiogram we cannot get it before the trial starts.
Okay.
So based on the, since we have a microbiology unit in our center, we do.
So, but at least till the time you complete the study,
Yeah,
the
let me-
bacterial culture would be available, isn't
Correct.
it? Yeah.
Let me complete.
please.
Let me complete. So we do microscopic studies only if it is bacteria, either gram positive or gram negative, and if there are no fungus on the KOH, then we recruit into the study.
Right.
We get the antibiogram reports after 3 days. Here we used moxifloxacin as a standard thing. Monotherapy with the quinolone is still being advocated, and fortunately 36 cases, that's why I said 36 cases could complete the study with single drug. If there was
Worsening.
a worsening, or if there was a need for any other drug, then we excluded from the analysis, but still it's an ongoing thing. So we are also thinking about having dual antibiotics. If it is gram positive, to go ahead with quinolones, gram negative to go ahead with the aminoglycosides.
Okay. Thank you.
That's
And
what is the
How
methodology.
frequently do you change the contact lens?
Only if it is lost, or if it is too much clogged or damaged. Otherwise we can just wash or flush and reapply.
For how
They're
long?
quite expensive.
How long? How many days?
At least for 3 days. That's what we suggest, at least for the 3 days, because we see effective healing within 3 days. So for the first 3 days we recommend the physician to have. After that, based on the clinical response,
And how frequently you call the patient for follow-up? Every day or maybe?
all these cases we admitted the patient because it's a RCT, but I think it's wise to call them at least once in 48 hours. Thank you.
Thank you. So the next paper is mini-slit versus CAG fixation with fibrin glue after pterygium excision, a randomized controlled trial. Presenting author is Dr. Siddharth Goel. Dr. Siddharth Goel, is he here? So then we go to the next paper, comparative analysis of posterior cornea between hydrops in keratoconus and HABs striae in PCG, Dr. Sohini Mandal.
Good afternoon, one and all. I am here to present my study on comparative analysis of posterior cornea between hydrops in keratoconus and HABs striae in primary congenital glaucoma. None of the authors have any financial interest to disclose. Acute hydrops in keratoconus occurs due to a tear in the pedial DM complex secondary to altered collagen and ground substance of the posterior stroma, resulting in corneal edema, which persists till a duration of 4 to 6 months naturally without any intervention. On the contrary, acute hydrops in PCG occurs due to a tear in the DM with altered PDL secondary to high intraocular pressure, resulting in transient corneal edema with spontaneous resolution within a span of 4 to 6 weeks. Acute hydrops of PCG often resolves on lowering of IOP if done in time, whereas descent membrane tears in keratoconus induces hydrops with very poor resolution rates. This differential response of keratoconus and PCG to posterior corneal tears is the subject of intrigue for us. Therefore, we aimed to compare the posterior corneal morphological characteristics both in vivo ASOCT and on histopathology between keratoconus and PCG, and there are no studies available in literature evaluating and comparing the morphology and of DM-PDL complex in keratoconus versus PCG eyes. This was an ambidextrous study conducted in RP Center, AIIMS, New Delhi. The ASOCT arm was conducted prospectively, while the histopathological arm was conducted retrospectively. The ASOCT arm comprised of 3 groups: 12 eyes of advanced keratoconus with healed eye drops, in which the acute eye drops episode was managed with intracameral 14% C3F8 injection alone, 15 PCG eyes with isolated trabecular dysgenesis who had undergone at least one trabeculectomy with trabeculotomy, and 14 healthy control eyes. Any other secondary causes of corneal ectasia, any history of corneal cross-linking or keratoplasty were excluded. Any other secondary causes of congenital glaucoma were excluded. High resolution in vivo ASOCT was performed to measure the DM-PDL thickness at 3 points in the central 6 mm of cornea, and an average of 3 readings was taken. The histopathological arm comprised of 3 groups: 14 tissue samples of advanced keratoconus with healed eye drops who had undergone penetrating keratoplasty, 13 tissue samples of PCG who had undergone PKP, and 6 enucleated retinoblastoma globes which served as controls. The cases whose cornea did not clear even after surgical control of IOP were included, and any other secondary causes of congenital glaucoma were excluded. Hematoxylin and eosin stain sections of the cornea were examined under a light microscope, and immunohistochemistry with collagen 4 staining was done to identify and differentiate the DM and PDL. Appropriate statistical tests were applied. Coming to the results, the mean age at presentation of the PCG group was significantly lower than that of the keratoconus group. The mean corneal diameter of the PCG group was significantly higher. The mean corneal astigmatism and the mean keratometry values was significantly higher in the keratoconus group as expected than the PCG group. Coming to the central corneal thickness, the central corneal thickness and the DM-PDL complex thickness within the area of the descent membrane tear was significantly lower in the keratoconus group when compared to the PCG group, and the height of the DM-PDL detachment as well as the length and the area of the DM-PDL detachment was higher in the keratoconus group when compared to the PCG group. Location-wise, the eye drops occupied a more central location in the keratoconus group compared to those of the PCG group, where the Hab stria occupied a more peripheral location. We noted 2 patterns morphologically on ASOCT, most common being the DM-PDL detachment on ASOCT with an excavation in the posterior stroma, followed by a posterior corneal bulge with increased corneal reflectivity in the keratoconus group. Similarly, in the PCG group, we noticed 3 patterns, most common being the intracameral twin protuberances, followed by a thickened DM-PDL complex, and the least common being a persistent DM-PDL detachment. The histopathological results corroborated with that of the ASOCT, with the mean age of presentation of the PCG group being significantly lower. The DM-PDL complex thickness inside the DM tears was maximum in the PCG group, followed by the keratoconus group, and then followed by the control eyes. Morphologically, on histopathology, hematoxylin and eosin stain sections of the keratoconus group showed a descent membrane PDL break with detachment with an excavated posterior stroma lined by a regenerated endothelium and a newly formed basement membrane. Similarly, in the PCG group, there was a persistent DM-PDL detachment with DM scrolls splits seen as shown in this figure. Therefore, the differential response of the 2 diseases, to understand this, why does keratoconus eyes decompensates more often after an episode of acute eye drops because of poor healing and regeneration of DM-PDL complex and endothelium, and the greater height and length of the DM-PDL detachment which is occurring due to the ectatic cornea of the keratoconus. On the contrary, PCG eyes are self-healing along the posterior stroma, leading to lesser incidence of corneal scarring and decompensation. To understand this question, why do acute eye drops in keratoconus have poorer resolution rate, we have hypothesized 3 factors. Firstly, the age of presentation of keratoconus being higher, they will show a lesser fibroproliferative response in and around the descent membrane tear. we are not primarily addressing the underlying pathology in the keratoconus group, that is the altered collagen and the ground substance, whereas in the hydrops of PCG, we are addressing the underlying pathology by reducing the IOP medically or surgically. Thirdly, the height and length of the DMPTL detachment is more in the hydrops group. So, to summarize, keratoconus cornea decompensates more often as the healing response is poorer and the height and length of the DMPTL detachment is more. It is still a matter of research on how to limit the posterior corneal injury in keratoconic eyes and repairing it as soon as possible by injecting air or by putting compression sutures such that the new endothelium can be regenerated could be helpful. Thank you.
Next.
Did you get any cases of corneal decompensation in your series?
Yes, ma'am. In the ASOCT arm, we did not recruit any corneal decompensation cases. We included only the clear corneal cases with a central healed hydrops in the keratoconus group, whereas Harbstria with a clear cornea in the PCG group. Whereas in the histopathology group, only the cornea which had decompensated and which had progressed to a stage in which the patient required a penetrating keratoplasty, those eyes were included in the histopathology group.
Okay, thank you.
Thank you.
So the next paper is on retrospective study of demographic clinical characteristics and outcomes of DSAEK graft rejection by Dr. Shalini Singh.
A very good afternoon to everyone. So I shall be presenting DSAEK graft rejection, a retrospective study of demographic profile, clinical characteristics and outcomes. So as we all know, the most popular technique for posterior lamellar keratoplasty today are DSEK and DMEK. But in a recent study conducted in US, the number of eyes undergoing DSEK was 20,000, whereas DMEK is 7,000. Hence, concluding that DMEK is still the surgery of choice, especially in eyes with complex anterior segment anatomy. So it is very important for us to understand anything which influences the outcome of DSEK. This is one of the study published by Das et al., according to which corneal edema post-cataract surgery is one of the most common indication at a tertiary care facility in South India. So coming to the purpose of our study was to evaluate the demographic profile, clinical characteristics and outcomes of DSEK graft rejection. It was a retrospective analysis of patients diagnosed with DSEK graft rejection from May 2012 to February 2019. 61 eyes of 61 patients were included, among which 6 patients were lost to follow-up after the first episode of graft rejection, hence they were excluded. A standard DSEK surgical technique was pre-cut tissue was used with a donor size of about 8 to 8.5 millimeter, and the DSEK lenticule was inserted into the anterior chamber using Sheets glide. Postoperative management included topical broad-spectrum antibiotic and steroids after surgery, which were tapered gradually and maintained at once or twice daily dose. Now shifting our gears to the results obtained in this study, the mean age in this study was noticed to be 52.44 with a range from 12 to 83 years. Females at 31.4% and male 68%. Laterality, there was no significant difference noticed between the right and left eye. In indication of DSEK, prior failed graft, that is post-penetrating keratoplasty or endothelial keratoplasty, was the most common indication noticed. One of the striking features which we noticed in this study was inflammatory conditions like toxic and viral endothelitis and iridocorneal endothelial syndrome had a high percentage of graft rejection. Coexisting parameters and comorbidities, about 64.81% of patients had associated comorbidities, among which secondary glaucoma was the most common comorbidity noticed. Clinical features, the endothelial immune response in a DSEK graft rejection, according to a paper by Price et al., is noted to be more subtle. In fact, in their group, most of the patients were picked up with graft rejection on routine examination. On the contrary, most of our patients presented to us with clinical complaints, and the most common clinical feature noticed was diffuse corneal edema, followed by keratic precipitates, and only one of our patients had a very severe grade 4 reaction with about 1 millimeter of hypopion. The time since surgery, most commonly, most of our patients presented with DSEC graft rejection within 6 months to 1 year. Now, the graft recovery in our study subject, about 31.48% of patients did not recover, 46.3% patients recovered completely, and partial recovery in 22% of the patients. So, we did a risk factor analysis for non-recovery among the patients. So, first, duration of symptom. Patients who presented to us within 7 days of graft rejection and later to 7 days, and when this analysis was done, as we can see from the p-value, that it was statistically significant that patients who presented within 7 days had a better chance at recovery. Number of transplants done before did not have an effect on graft recovery. Neither did IV methyl prednisolone administration. Many of our patients, when presented to us, were using topical steroids, and some of them were not on topical steroids, but using topical steroids when complaints started did not have a significant role in graft recovery among this study population. Coming to endothelial cell loss rejection, the endothelial cell, this is one of the clinical photograph of our patient where we can see the cell loss after a rejection episode was almost of 50%. So when mean value was calculated, it is almost 38.87% of cell loss noticed in most of our patients. So the factors influencing graft recovery according to this study was young age, poor visual acuity at presentation, and later presentation, that is almost after 7 days. When compared to other studies, our study had DSEC graft rejection in a younger age, that is 52.44. Indication of DSEC in our study population was failed graft, and as we can see from this table, ocular comorbidities, that is secondary glaucoma, was the most common association, which is similar to reported in other papers. Time point of first rejection was 3 to 12 months, which is again similar to the results obtained from other studies. Thank you.
Thank you. I just wanted to ask you one question. You said there are one patient having hypopion.
Yes.
So how do you correlate hypopion with graft rejection?
Sorry, ma'am, I did not get your question.
How do you correlate hypopion with graft rejection? Was it a graft rejection or what? It was some endogenous infection?
No, it was hypopion because when the patient presented to us, he had significant corneal edema. There were keratic.
Normally during graft rejection, you don't see hypopion.
Yeah,
so could it be some inflammation inside, inflammatory hypopion, which is being considered as graft rejection?
That patient was a patient, like the prior indication for the patient for DSEC was pseudophakic bullous keratopathy, and this patient had developed hypopion after, like graft rejection after 3 months, and this was a patient we had given IV methyl prednisolone also, and I think 2 days later itself he had completely recovered. So we did not correlate, like there was no other inflammatory pathology suspect.
Thank you. Thank you, sir.
One question from my side.
Yes, sir.
When endothelial line of rejection will happen? Graft rejection.
Sorry, sir.
Endothelial lining of graft rejection, when it will happen?
When it will take?
He meant to ask, in case of rejection, at what point of time after rejection you can see endothelial line of rejection? I mean, how many days or immediately after in the acute phase, immediately you start seeing the line? That's what he meant to ask.
I'm not sure.
So that was rejection line.
Yes, ma'am.
When will it appear? At what stage? The first day of diagnosis, you see a line.
On first?
Day when you see the patient.
No, sir. No, it at least takes 3 days for the endothelial graft rejection line to be seen.
Come to any conclusion why glaucoma patients are having higher rate of rejection, or it's just because of altered immunity because of using drops, or or the previous pathology, maybe complicated cataract surgery or whatever, which has already damaged the trabecular meshwork. So any common factor or anything you could find?
So actually the most of our patients, like where we have seen secondary glaucoma, they have developed glaucoma like after, many of them were associated with failed grafts after post-penetrating keratoplasty or after endothelial keratoplasty, they have developed secondary glaucoma. So that was our one of the thing. Complicated cataract surgery, no, I don't think we came across.
Okay.
No, no, not complicated cataract surgery. Most of them were mostly just secondary glaucoma developed after
So
graft.
you mean to say the glaucoma itself, or probably the drugs, or whatever we use to treat the glaucoma, that has predisposed for them to cause the rejection more?
It could
Maybe
not.
altered ocular surface following the frequent use of glaucoma drugs?
Yes, that could be one of the factors.
Just a hypothesis, yeah.
Yeah, that could be one of the factors. But apart from that, even more glaucoma patients, their aqueous humor itself is also altered. They have
Right.
more inflammatory mediators in their aqueous humor. So that could also be one of the cause that why they are more predisposed to graft rejection post DSEC. But it is just a hypothesis. We have not come to any conclusion.
Thank you.
Thank you.
Okay. Then we go on to the next paper to evaluate the efficacy of perilesional subconjunctival interferon alpha 2b in the treatment of OSSN by Dr. Kiran Kumar.
Respected teachers and good afternoon everyone. I'll be presenting my work on subconjunctival perilesional interferon alpha 2b for ocular surface squamous neoplasia. As we all know, the management of OSSN has been evolving over the past decade with better understanding of the disease pathogenesis and improved diagnostic and treatment modalities. This is an interesting study of a number of OSSN cases which were managed successfully with the perilesional injection of interferon alpha 2b. Due to the COVID-19 pandemic, many patients have become very difficult for them to follow up, and complaints of the patients has actually taken a backseat. And this is one such patient which is presented to us with a very large nodule without any access for healthcare for nearly about 18 to 19 months. So this is a clear-cut case of OSSN just by macroscopic features, but still we got it confirmed by impression cytology, and the diagnosis of OSSN was made, which was further seen by ultrasound biomicroscopy, and there was luckily there was no any intraocular invasion as well as pre and post-septal extension. So this was successfully managed medically, and we were able to give him a clear corneal or ocular surface without any damage to limbal stem cells. With this background, if we see our preferred practice pattern in our institute, we usually classify into medical and surgical, but whenever as per traditional method of treatment of OSSN, if we see any clear vision, the first thing which comes to our mind is wide local excision with alcohol epithelectomy, with cryotherapy of the bed with amniotic membrane transplant. This is okay for this kind of solitary lesions. But what about the lesions which are very diffuse, which cannot be excised, where we cannot compromise our limbal stem cells, as well as also in wide local excision, there is almost like 10 to 20% of the recurrence rate in the literature. So there came the concept of medical therapy for OSSN with mitomycin C and 5-fluorouracil, which inhibits DNA synthesis, and it has to be given weekly on and off cycles for 6 to 8 cycles. It almost takes 12 weeks. The most important thing needed here is patient compliance, and also the many side effects. Like the most common thing with mitomycin C is ocular surface toxic, persistent epithelial defects. It might even lead to scleral melt. So in order to overcome this, later on they introduced immunotherapy in the treatment of OSSN, where interferon alpha 2b was used to given as a topical dosage of QID of 1 million international units per ml. But here the problem was we have to refrigerate the medicine, which is very unlikely and a big problem in a rural setup in India, and lesion almost takes 12 to 14 weeks. With this background of the problem with surgical excision as well as chemotherapy and immunotherapy, we came out with a new concept of like subconjunctival perilesional interferon, wherein we give 3 million international units per 0.5 ml. This is basically based on the principle of delivering high dose target immunotherapy at the tumor site with bare minimum systemic and local side effects. So our aim of the study with this background is to evaluate the efficacy of interferon alpha 2b by giving in perilesional subconjunctival route in OSSN cases. It was a prospective interventional study which was conducted in RIO Bangalore, wherein we recruited 68 patients with histologically proven corneal and conjunctival OSSN, and every patient were given 3 million international units in 0.5 ml. And if lesion is more than 3 clock hours, we used to give 6 millions, and if it's more than 6 million, we used to give 9 million international units in 1.5 ml. And patients were followed up weekly with clinical and photography monitoring until complete resolution of the tumor. Now this was the study flow, like patients coming to our specialty clinic where with complaints of primary or recurrent conjunctival or corneal OSSN were recruited. Almost 68 patients and routine regular complete ophthalmic examination. The main thing in OSSN is like in slit lamp we have to see for intraocular invasion signs like NVI or intraocular inflammation, and even lenticular cataracts. And the most important thing here is to do ultrasound biomicroscopy in each and every case to know for the intraocular invasion. And the one thing is impression cytology, that is to confirm the cases. This is a simple technique which we give. This is basically, as I told, like high-dose target chemotherapy, which is delivered perilesionally. We usually give it with tuberculin syringe with 30 gauge needle. The point of entry should be at least 5 millimeter away from the tumor margin, which has to be stained with rose bengal to delineate the lesion properly. And a endpoint will be complete ballooning of the conjunctiva around the lesion. Previously, we used to do this in operation theaters, but most of the patients in our study were like retro positive, and getting them ready and getting systemic stability before taking him to OT is a big concern. So we started giving in on a simple slit lamp also. The end point, as I said, it should be like complete ballooning of the conjunctiva around the lesion. There are a few tips which we followed for the better response. It should be like complete ballooning around the lesion, and better to avoid any subconjunctival hemorrhage because it will interfere with our tumor monitoring, tumor response monitoring. And appropriate statistical analysis was done, and patients were monitored closely with regular biomicroscopy and dilated fundus examination, because literature says sometimes interferons might be associated with retinopathy, but none of our patients developed any retinopathy features, and lesion is measured at every follow-up. Clinical resolution of the tumor was achieved in 95% of the cases. With the mean follow-up of about 19 months, there have been no recurrences. There was failure of response in 3 cases. Actually, it is not failure, we achieved only chemo reduction. Complete tumor could not be resolved, so that was managed in term by surgical excision. And these are few cases which responded very well. So with this, I would like to conclude, like subconjunctival interferon injection is safe and effective alternative, which ensures better patient compliance with lesser local side effects. Thank you.
What is the mechanism of action of this interferon?
So it is actually an immunomodulator. It also induces apoptosis, tumor apoptosis.
Do you think that these patients need to be excise the tumor later on? Otherwise, in the long run, they can have recurrence after say maybe 5 years.
Yeah, till now our study longest follow-up is for about 36 months, and we have not seen any recurrences. Our follow-up protocol is like initially we follow up, after resolving we do an impression cytology to confirm whether it is resolved or not. Once we confirm, we follow them up every weekly for 3 months, then we follow up them every 4 weekly for at least 6 months, then every 3 monthly till 3 years. And we have not seen any recurrences till now.
But 2 patients with squamous cell carcinoma, they develop recurrences up to 5 years.
The 3 cases were like pigmented lesions, and they were retropositive. They had chemo reduction. In those cases, we surgically excised.
After chemo reduction?
Yeah. With
it
interferon.
was just fine. They didn't have anything for 3 years. And then after 2 years, they came with recurrence.
No.
So
This
5
was
years follow-up, there are some cases of recurrences.
Yeah, we need to see, ma'am. We have only 3 years
So
follow-up.
do you advise excision of these patients after chemo reduction?
Yeah, chemo reduction, those patients were managed by surgical excision, and now they are tumor-free.
Okay, thank you.
Thank you.
Okay. The next paper is on predictive accuracy of Barrett's TK toric calculator compared to measured PCA using pentacam by Dr. Ashlyn James Joseph.
Good afternoon to all. I'll be talking on a study on the predictive accuracy of Barrett TK toric calculator compared to the measured posterior corneal astigmatism using pentacam in toric IL power calculation. I am Dr. Ashlyn James Joseph and my co-author is Dr. Tamilarisi S. ma'am. I have no financial disclosures. So cataract surgery has now become more of a refractive surgery and the aim is to achieve post-operative emmetropia and spectacle independence. More than 40% of the Indian population has high levels of corneal astigmatism at the time of cataract surgery. So it should be dealt with. In the past, posterior corneal astigmatism was ignored. This led, it has a value of 0.3 diopter against rule astigmatism. So it can lead to overcorrection in eyes with the rule astigmatism and undercorrection in eyes with against rule astigmatism. Douglas Scott said that posterior corneal astigmatism should be taken into consideration while calculating the total corneal astigmatism. Total keratometry is a new keratometry value that is incorporated in the IOL Master 700. It uses telecentric 3-zone keratometry and a swept-tooth OCT to measure the total corneal astigmatism. The pentacam uses a rotating stream flow camera to measure the anterior and posterior corneal surfaces, and this data obtained can be used in standard toric IOL calculation. The aim of the study was to compare the predictive accuracy of Barrett TK toric calculator to measured PCA using pentacam in toric IOL power calculation. The primary objective was to compare these two methods to the Alcon online toric calculator, which has the Barrett toric calculator incorporated in terms of the mean absolute prediction error, and this was calculated as a difference between the actual post-op refractive astigmatism and the predicted refractive astigmatism. The secondary objectives were to find the magnitude of preoperative corneal and postoperative refractive astigmatism and to find the percentage of eyes with prediction error less than or equal to 0.25, 0.5, 0.75 and 1 diopter. The study was conducted at Eye Foundation Hospital, Coimbatore. It was a prospective comparative study done between September 2019 to May 2021, and the duration of follow-up was for 6 weeks. The inclusion criteria included patients above 18 years with age-related cataract who had regular corneal astigmatism above 0.75 diopter, willing for regular follow-up. Exclusion criteria: any pathology which might preclude accurate manifest refraction, case of post-op toric IOL misalignment, small pupils or resurgeries were excluded from the study. The sample size was calculated as 118. Pre-op evaluation included history and all other routine investigations. Toric IOL power calculation was done using 3 methods. The IOL selected for the study was Accuracy of IQ, which is having aspheric hydrophobic material and has a good rotational stability. So the calculation was done using the online toric calculator. This was done routinely in an institute, and the IOL power with the least residual refractive astigmatism was selected and the value was noted. The value of residual refractive astigmatism from the Barrett TK toric calculator was also noted. Pentacam evaluation was done and values of the posterior cornea were noted. And then we used the online Barrett toric calculator. Values from the IOL master were entered, and then we select measured PCA instead of the predicted PCA, and we enter those values from the posterior cornea of pentacam, and we calculate to get the total value. And here we note the value of the refractive astigmatism, and IOL implantation was done under Virion guidance. So the results: 90 patients were included in the study. It was done unilaterally in 62 eyes and bilaterally in 28 eyes. 54% was OD and 45% was OS. Majority of the eyes, patients were in the 60 to 69 years age group, and majority were males. Most of the patients had against rule astigmatism of a magnitude between 1 to 2 diopter. The mean keratometry value was 1.46 and the mean IOL power was 20.78. Post-op refractive astigmatism was less than 0.5 in majority of the patients, more than 85% of the patients. And comparing the 0.25, 0.5, 0.75 group, it's similar in all the 3 calculators. Repeated measures ANOVA was done between the 3 calculators and it was not significant. And post-hoc Montferny assessment was also done between the calculators and it was insignificant. Similar results were obtained in the against rule astigmatism group, with the rule astigmatism group and oblique astigmatism group. And compared to previous studies, the results were similar. The limitations was different IOL models should have been studied, and we should have compared other industry toric calculators also. And we should have done direct measurements in unconventional cases like post-LASIK cases. So conclusion is posterior corneal astigmatism should be taken into account in toric IOL power calculation. The Barrett TK toric calculator and measured posterior corneal astigmatism of pentacam has similar predictive accuracy to the online toric calculator, and since it is not outperforming, We can continue using the predicted posterior corneal astigmatism till we develop a technology that will supersede this. And the Barrett-TK toric and the updated Barrett toric calculator might give a better predictive accuracy in post-refractive surgery eyes, and these need to be studied. These are my references. Thank you all.
What was the SIA used?
We used 0.1, sir. Previously,
Was it calculated?
Previously, we have done studies in our institute, and routinely we are
This
using
was
0.1.
for the particular surgeon. They say this was a
Yes,
single
for
surgeon
the surgeon.
cases.
Yes, sir.
So for that surgeon, you have calculated SIA.
Yes, 0.1. Previously, they have calculated, sir. So we
0.1 for 2.2 millimeter incision or 2
Yes,
millimeter.
sir.
Okay.
Yes, sir.
All cases were done by single surgeon.
Single surgeon, sir. We had a 1.5 year time was there, sir.
Okay.
Thank you.
Now we have the last paper for this session, effect of HPMC in thin cornea less than 400 microns, a 6-month study by Dr. Charuta Shrotriya.
Good afternoon all. My presentation will be on the effect of HPMC on thin cornea, that is less than 400 microns, and this was a 6-month study. So as we know, keratoconus is a chronic progressive ectatic disease of the cornea, which is characterized by progressive stromal thinning. Now collagen cross-linking is a novel treatment option to halt progression in keratoconus. It induces, increases biomechanical stability of the cornea via photooxidative interactions. Now, several moderate to advanced cases of keratoconus, they have a pachymetry of less than 400 micrometers at presentation. Therefore, currently a modification in the standard protocol is required. The purpose of the study was to evaluate changes in thinnest pachymetry, posterior elevation and topographic K values after CXL using isotonic riboflavin solution with HPMC in patients with progressive keratoconus and pachymetry less than 400 micrometers. Associated changes like BCVA, CCT and apex pachy were also evaluated, and a statistical analysis was done at a preoperative period and 6 months post-op follow-up. It was a prospective comparative interventional study which included 20 eyes of 20 patients of progressive keratoconus. All patients underwent a thorough ophthalmological examination and measurement of topographic indices and pachymetry both pre and 6 months post-operatively. We included patients who were of the age under 40 years with documented progressive keratoconus and a pachymetry of less than 400 microns. Patients with scarred corneas, any autoimmune disorders, corneal ectasia which was not caused by keratoconus, pregnancy and a history of prior CXL treatment or other ocular surgery were excluded. So this CXL was performed by the same surgeon under topical anesthesia with the epithelium off technique, and the stroma was saturated with isotonic riboflavin solution 0.1% with 1.1 HPMC as the carrier, and primary outcome measures included changes in thinnest pachy, average mean posterior elevation and topographic K values as compared to pre-operative values. Additional outcomes included BCVA along with CCT and apex pachy. These are the results. BCVA showed a significant improvement, and thinnest pachy, though there was a slight decrease, it was not significantly, there was no significant difference in the pre and post-operative values. Even with topo K, it remained stable and there was no significant between the pre and post-operative values. Posterior elevation, though there was slight increase, it was not statistically significant, and central corneal thickness also remained stable. The additional Kmax and apex pachy also remained stable with no significant difference between the two, between pre-operative and 6 months post-operative. So, standard CXL technique cannot be applied in thin cornea due to safety reasons. So, there are several modifications which have been proposed, such as the use of hypoosmolar riboflavin. But however, there is no standardized procedure for the treatment of thin corneas. In our study, we have used isotonic riboflavin with 1.1% HPMC as the carrier. These are some of the similar studies that we referred to. Though these studies use the same parameters and the same technique, Our study differed in the way that we did a 6-month follow-up while these studies were of a short-term follow-up. So in conclusion, I would like to say that at the end of 6 months post CXL, we found that there was no significant changes in the reduction of CCT and thinnest pachymetry and posterior elevation. The K-max reading showed stabilization after CXL, while topographic case showed almost 1 degree diopter regression, and BCVA remained stable at the end of 6 months in post-CXL eyes. So isoosmolar riboflavin with HPMC is a safe and sustained surgical technique for thin corneas, but further studies with a larger sample and longer follow-up are needed to assess the efficacy before the procedure can be applied on a larger scale. Thank you.
What is the rationale of using this thing?
Ma'am, as I mentioned, the standard protocol that exists cannot be applied for thin corneas because of safety reasons that damage to deeper ocular structures. So we have to come up with new modifications to the standardized technique, because around 20% of patients of moderate to advanced keratoconus, they present with a pachymetry of less than 400 microns. So for these patients, we have to employ newer techniques. And
what is the role of viscoelastic? I mean,
ma'am, there is the viscoelastic causes an iatrogenic swelling of the cornea artificially, and this is also seen in the technique where hypoosmolar riboflavin has been used. But unlike hypoosmolar riboflavin, the increase in thickness with HPMC is not transient, and yes, ma'am, it is not transient, and it forms a precorneal tear film, which also seems to influence the increase in corneal thickness by preventing evaporation.
Thank you.
Slightly on a different aspect, the entire base of your study is that in thin corneas, the cross-linking or the ultraviolet A rays can damage the endothelium, right? So have you come across any studies before starting this study which has shown that the ultraviolet rays have damaged endothelium during C3R? Have you read such human studies? How many studies?
Wolinski et al. Has conducted a study where they proved that it caused...
No, were there any cases?
Yes, sir.
So what you're talking about is about rabbit eyes,
yes,
right?
Sir.
So they have studied rabbit eyes and they have come across that the endothelium in the rabbit eyes at this particular level of UV radiation concentration, 5 millijoule, the amount of UV rays which reach to the endothelium is toxic to rabbit endothelium. Yes. But now, have you read recent studies about it? So there have been recent studies which have been done on the eye-bank corneas, and now people are saying that these human endotheliums are not, they are quite resistant to these UVA rays, and it might not, this particular radiation dose might not affect the endothelium, and we may not require these modifications. We can go ahead safely in most of the corneas, and now those studies are coming up. I think you should study those those papers as well.
Yes, sir.
Yeah. Thank you.
In the technique, you actually you used a layer of HPMC along with riboflavin.
Yes, ma'am. The HPMC acted as a carrier, and that caused iatrogenic swelling of the cornea.
And which protocol did you use? The standard one or the accelerated protocol?
Yes, ma'am.
Okay. Thank you. Thank you so much.
Okay. Thank you, everyone.